Hello everyone at the Agile meeting. Appreciate this is the last session. Bob Smith and I are preparing the position statement on international collaborations for screening equity. So, variety of questions. What are the factors that impact starting a low-dose screening program? Is it national lack of evidence, no available funding, lack of infrastructure, or actually no strong advocates in the country? We also want to look at geographic equity. Not every country has the budget to consider lung cancer screening. What assistance do they need? We may have to consider modifying the screening program. If there's no national patient register, consider utilizing a biomarker to identify high-risk individuals and then bring them through each stage of participation. Question we should ask is, what role do conferences play? Including educational exposure, providing access to expertise. How can the international community assist? And can Agile assist? Setting up with various databases and learning, what is the background experience of each country? Should we share infrastructure such as databases, AI systems, protocols, end-to-end IT systems? We need to understand, can screening start as research collaborations, feasibility studies funded from external grants or even industry? Possibly the industrial partners can provide equipment, be it CT scanners, possibly software, maybe databases to actually run the whole programs. We need to ask the question, the protocols that are knowingly not as good as high-income countries, is there an ethical responsibility, and for whom? Are there other approaches that can be used in middle to low-income countries with socioeconomic deprived communities? We should also consider alternative approaches, utilizing data from chest x-rays to identify lung cancer using AI, possibly using the current TB programs to include lung cancer screening. So the question is, how can the international community assist? I want to leave you with this particular piece of work. Socioeconomic impact of lung cancer screening also is an issue in developed countries. And if I give you an example, in the UK, around 50% of individuals are invited to the NHS England targeted lung health check. But that actually means 50% don't participate. And these are mainly from socioeconomic deprived communities. But there's also good news if we look at the UKLS data, where actually socioeconomic deprived communities, where they participate, there are major gains. So if we look at this here, the lung cancer diagnosis, and this red line is Q1, Q2, which is the lowest socioeconomic group. These individuals had a CT scan, and they are the most deprived, compared to the blue line, which is the control group. So for the more deprived quintiles with low dose, the rates were the same as for the higher quintiles down here, where death from COPD is less common. But also, what we found here when we looked at death of COPD emphysema, time to death due to COPD or emphysema was noticeably shorter in the most deprived group. See this blue line here, miles above the other. So therefore, we can actually demonstrate that individuals who are from this lower socioeconomic group, who are brought into CT screening, gain considerably. We want to try to look at how we can bring this together as a position statement, and anybody in the audience or in fact online who wishes to be involved, please get in touch with Bob or myself, and we would be great to have you as a collaborator to develop this position paper. Thank you.
Is John Setti? There he is. Okay. Hello, John.
Hi.
Very nice. So we have a little bit of time here to anybody that has some comments on the PowerPoint that we just presented. But one thing that sort of strikes me Okay. This is why I never had a career as a lounge singer. I'm inept when I'm holding a microphone. Uh, we talk about doing this, and we've all listened to the appeal for finding ways to help people deal with equity. And what you always end up with is kind of this Brownian motion. It's like when I tell my kids to clean their room and they would pick one thing up over here, one big thing over here. We really need to do this in a fairly orderly way. And I think John made a very good point. We have disequity all over the world. We have it in our countries. And one of the things we don't do well at is just simply inventorying where those inequities are. I mean, Ray, who's going to join us this effort, showed the disparities in his state. In every state in the US, you can find areas that are not well served by health services, areas that have persistently elevated high rates of advanced disease and do much worse than other areas. And this is in a high resource country. So there are going to be in every country some people who are eager for change, and that would be one challenge, is a challenge to seek them out and tell them they have a home here. Anything that we can use with international databases to help quantify the burden of disease and the disparities in the burden disease in countries would be of assistance. Logistics is key. What kind of inventories do we have of health resources, of equipment? I was talking to one of the attendees out at the break the other day, and I said, with respect to chest X-ray and film versus digital, how do we get an inventory of what equipment is available, what it would cost to upgrade it, the whole issue of implementing lower technology as opposed to striving to implement the state-of-the-art technology is something we'd always have to keep an eye on. But I think we also can't agonize over the perfect being the enemy of the good. We do know that we can save lives with these technologies. We, on the issue of education, webinars are a way to reach anybody with the internet. One of the things we've done in the US that Ray's been involved in is doing these echo clinics, and we've done them on biomarker testing in 13 states now, I think, something like that, where you basically have people from all over the state who need to find ways to improve biomarker testing in their communities come together to talk about how they might do that and how they might actually share resources. So the challenge, I think, for this particular paper is, if you were to use a baseball metaphor, how do we start hitting some base hits as opposed to waiting to hit a home run? So, any comments? All right. So, is John, anything to add?
I think actually the way we need to look at it is that we have to try and consider certain countries that may be wanting to set up screening programs, but actually have neither the economic nor the, let's say, know-how. And Agile may be able to assist them in developing a program and also helping them possibly with external funding to set up feasibility studies. And every country in Europe is involved in feasibility, and we were many years ago, and we've managed to come through the whole route. So it's actually starting the ball rolling. And your metaphor from your own sport, it's not the home run. It's actually just getting the game started, I think is the important point.
So we have developed toolkits that actually focus on that. How do you get started? And it may be that you would just focus on within your own institution. How do you get started? Ray?
Give a shout out to the IASLC. I think earlier this year, we had for the first time a meeting sponsored by ISLC officially sponsored by ISLC in sub-Saharan Africa. We had a meeting in Accra, Ghana. David and Claudia were there talking the early detection talk. There was a lot of interest, and now one could rear back and say, wait a minute, surely they have all these other problems. Why would we even begin to think about screening for lung cancer in places like that? But the reality is people are dying of lung cancer there. Yes, these are resource challenged areas, but if anybody is ever going to grapple with that problem, it is a group like this that has such expertise that can guide the adaptation of knowledge and approach to suit such environments. We know that treatment for advanced lung cancer, stage 4, with all the fancy, budget exhausting treatments that we have today, if anything, is absolutely not applicable to environments like that. So if we do believe that early detection is a cost-effective way to grapple with this problem, it seems like those societies, even more than others, need that approach, not the incredibly inefficient treatments for stage 4 and advanced lung cancer. So I would hope that we don't dismiss the possibility of early detection in low middle income countries. And this effort, I would implore, should expand to engage such environments.
Very good. Thank you.
I think it's important to remind that the staging ground for that meeting in Africa was the first Agile meeting. So I think Agile definitely in its DNA wants to really push these kinds of initiatives.